series of really impressive presentations. And we're continuing with Sam Lamb, who's been a long-term colleague and recently good friend of mine. Sam's got a great reputation in several areas, including my area that's dear to me in hair, but he also has a great reputation for being an expert in fat grafting. He's going to be talking about that. Sam's in practice in Texas, and his lecture is entitled My Personal Technique for Autologous Fat Transfer. It may be the last lecture on hair grafting, on fat grafting, but certainly going to be a valuable one.
Thanks, Jeff. Thanks, Jeff. Okay, let me make sure I got all my things here ready to roll. All right. Well, thanks for all you guys staying late to hear the second last talk or last talk. Book disclosure. We have to start understanding before we execute, and so this talk will be on thinking, seeing, and also doing, and all those components. And if you look at Sharon Stone over a period of 20 years, it looks very much like there's gravitational component that's very heavily based here. But if you look at the brows, they really haven't fallen much, maybe not even at all. And if you take a look at the dermatochalasis or eyelid skin that's come down on this side, if you look at the other side, it's actually retracted up a little bit. So there's a large component where we look at gravity being the principal mechanism of aging, when I think that it's actually potentially a much smaller potential out there. So in the effort to communicate with patients, I think simple models are important. And if you heard my talk yesterday at 12:15, I was really gearing the talk more toward ability to communicate with a patient, because with good communication, you stave off problems down the road, but you also help communicate and deliver an understanding of why to do something. So I like to say that when you're young, you're a grape. When you become older, you become a raisin or dehydrated. And why should you stretch and pull that raisin into a pea because it doesn't look the same? Instead, maybe we should reinflate it to a grape. Now, clearly an oversimplified analogy, but one that at least maybe helps patients understand when they go back and look at their old photos. I think the big problem today, as you see, is that in the past we used to have way over lifted faces, and now we're seeing this way over filled faces called pillow faces that are certainly unaesthetic. So the caveat here is always go less. You can't take the fat out. Go conservative before you start becoming aggressive. Get some feedback onto what's beautiful for you. You can always add fillers, you can always go back and add fat, but you have a hard-pressed time taking it out. The idea here is using the analogy of the glass of water. I like to use this oftentimes with my patients in the preoperative setting. They understand that I'm not here to make them too full. And when they understand that, they have the sigh of relief. I think the most important thing is to say, look, I know what you see out there with the celebrities. I'm not going to do that for you. If they hear that, there's a sigh of relief usually. And they're not so worried that you underfill them. They're worried that you're going to overfill them. And that's unfortunately something that's been a real problem in the last few years. So this little idea, and when you ask patients when they like themselves the most, you've heard me say this, particularly for women, it's around 30-ish or so, because really oftentimes when they're much younger, there's a lot of baby fat, there's roundness. So with the constraint of keeping the weight the same over your lifetime, there's this ongoing depletion of the face. And so volumization to an adequate level is helpful. Using the old photographs, to me, are not helpful for me to guide my surgery, but it's helpful for the patient to understand that I'm on the same page with them. So that's sometimes what I usually do. So, shape. Instantaneously, we look at someone and we can tell their age. We can tell their age even 20 feet away, and it's due to two things. It's the way that light and shadows fall on the face in natural lighting, which we won't be talking about too much in this talk, but also the visual shape of the face. And so when we're young, we have this very full round face. It becomes sort of a hybrid triangle and in the 30s, and then it continues to progress toward a triangle, and then it becomes more lower dominant, maybe some weight gain or ongoing volume loss. So I like to take that 30-year-old idea and make it more of an oval. So this is the idea here, is that ovalization is really what I like to do. So designing faces, I like to create ovals. And how do we do that? Well, let's take some examples and go through that. Here's a lady that I did a rhinoplasty and also I did a fat transfer for. And if you look, she's got a relatively heavy lower outer face. So you don't want to help the buccal area, you want to de-emphasize it. And so another analogy I help people understand is thinking of a glass of water on a television screen. If I ask you how big is this glass of water, you would say I have no reference points, I don't know. If you compare it to a shot glass, it looks large. If you put a pitcher of water next to it, it looks small. So it's all relative size issues. So this is what, if you put volume into the anterior chin and to the cheek area, it just looks like the buccal area is small, and that's the number of cc's I put. To be very frank with you, it doesn't really matter the number of cc's I'm putting. You're going to have different take and different results with the volume. I just want you to understand sort of the artistic component of how I design a face. Here's a lady here that is half Asian, and she's relatively fuller in the buccal, but not too much. There's this little bit of loss there, so I just put a little bit inside there, and a little bit less aggressive in terms of total volume around the face, and a little less aggressive on the outer cheek, because I don't want to widen her face too much since she has Asian qualities. There's a lady here. If you look at her, she's relatively flatter and hollower, and there's some buccal loss, but not terrible. And so you put a little bit more in there, and you create a little bit more harmony. You start seeing the ovalization. I used her as an example where I touched her up with fillers. This is just a raw fat result. But what I started to do was I add a little bit more volume here. And what I like to do is try to take this scalloping, this double concavity, into a double convexity. Something I haven't published yet, but I'm actually writing it on the plane going back. And the idea of a double convexity is really where I'm going toward understanding beauty. When you don't see the scalloping of bone right in the central zone and you join the two areas with soft tissue, it just looks much more elegant. So here's a lady here. Again, you can see that she's got a little bit of buccal suppression. Her lower anterior cheek is relatively full, so you want to bring some more attention to the outer upper portion so the face looks more in harmony, again creating a nicer oval. This lady is much more depleted. You can see that, in my opinion, she needs much more volume, especially into the buccal zone, especially toward the lateral area where you see that bony scalloping that's going on. And so this is just a nice way to create a little bit more of a harmonious shape. This lady is even more depleted, and you can see a lot of volume loss, especially toward the lateral aspect where that scalloping is much more dramatic in that bone. When you see that zygomatic arch starting to show, to me it's one of the most important areas to fill. So we'll talk in a moment more in detail about breaking down the buccal zone into subcomponents, but this is the medial buccal hollow, central buccal, and then the lateral aspect. By the way, I'm not showing you all the volumes. I'm just focusing on the area that I think is the most confusing and the area that requires the most artistry. And this lady here is centrally buccal, very hollow. So this is the zone right here that's important. I really filled her up well, and that creates a more harmonious shape. And this one, obviously, to me, equally, if not more so, depleted, and just really creating harmony, but I think the anterior cheek needs a little bit more, so there's better blending in this area. Obviously with some neurotoxins. So I like to, if you've heard me speak, I've used this before, and I think it's a way to visualize a face. If you take a look at the photo here, first of all, this is 37 years old, this is 42, so about 5 years after a fat transfer. Only put about 15 cc's in, very, very little, but it's held well for her despite her aging. And if you look at this photo of these two ladies, this is my patient here at 42, and this is her identical twin sister who's never had anything done. And if you look at them, there's something instantaneously, what Malcolm Gladwell talks about, in a blink of an eye, she looks younger to you. And this one looks older. And if you start to use your plastic surgical acumen, you may think, well, the nasolabial grooves need to be filled, the lips could use some enhancement, the brows could be tucked up a little bit, the jawline's a little slack, the things that we usually look at. But let's take a look. That jawline is as straight as this one. This one actually has a little more volume. And the lips are actually painted a little bit fuller than hers. These are paper thin. The nasolabial grooves are the same depth. The brow is a little bit more higher arch, maybe the way she's lifting it. So what I'm saying is that everything we try to blame is not present here. It's the issue is the anterior chin hollow, the outer cheek hollow, and the brow suppression where it's more bony articulated instead of soft tissue. And so that's why this face looks younger to you. And if you go back to see when she was a professional model at 32, you can really see that the way that you look at this lady here is the way that you emotionally relate to her here. And again, using your right brain, not your left brain. That's, as surgeons, we tend to be too technical instead of more artistic. And her sister looks like herself at 37. Longevity, does fat last? Absolutely it lasts. And that's why it's great, and that's why it's bad. And that's why you have to be careful with it. And so as I started to understand and look at longevity, I was studying for my hair boards, and I thought, wow, this makes sense. It's almost like a hair transplant, because over a period of time, there's going to be these processes that it gets better. And so I looked at my results over time, and I think that's the part of the problem is people that are doing fat grafts are not looking at their long-term results, they're not following them, so they give up at 6 weeks, they give up at 4 months. And I always try to caution my patients to tell them, look, at 4 weeks, when everything's stretched out and you've got a little bit of edema, things look almost too good, so be careful with that. So I don't want to say that it just gets better over time. It goes through a period of time of artificial improvement, then a drop. So I talk about this analogy of the dip, which is we go through swelling to maybe an ideal, we lose it, and then the results over time get better. Now, not all the time. Sometimes you need a touch-up at this point if it's not improving, but this is really where I see things going. And then obviously there's going to be further aging. That glass of water is emptying further, something you have to clearly identify to a patient in advance. So there's a lady over time, this is a week out, looks swollen, some bruising. And then at a month, I think she actually looks still a little bit too full, but I think still looks good overall. I wouldn't argue against that. And then, 3 months, maybe it's good in some ways, and sometimes I see more of a dip, sometimes I see less. Then 6 months, and the idea is that it's not so much that it's a dip or not a dip, it's just an evolution. And I think it's very important to photograph your patients every 3 months with standardized lighting, with standardized photography, and try to look at those changes over time. And so I think there's this evolution. The only other thing I did for her was neurotoxin, but you can see that nice change over time. Donor dominance, another idea taken from the world of hair that I've extrapolated into the world of facial plastic surgery. What that is that hair that's moved from the back of the head into the front actually behaves genetically like the hair on the back of the head. Well, I find that actually is quite similar for fat as well, because the fat in various parts of our body and our face act differently. So the one thing you have to be very careful with is that the fat taken from the belly and thighs have a wonderful tenacious hold, but there's also this tendency toward weight accumulation. So if someone gains 20 or 30 pounds, you have to really be careful. And that's why I think in someone in an adolescent phase, when you're using it to either rebuild a mandible that's missing or something like that, to be extremely careful not to use it as a bioinert substance, because it's actually highly bioactive. In some respects, great. You heard about adipocyte-derived stem cells, fantastic. As you know, fat in the abdomen and the thighs is about 21% stem cells. But one cautionary thing is not to oversell and overpromise people. I don't talk about stem cells as a stem cell facelift. I think it's an oversell because the results are variable. I'm not concentrating the stem cells. So I think you got to be careful with putting that in your advertising or trying to tell patients that you're going to create such a remarkable change. And the other thing that's important is, there are a lot of modalities out there to improve fat take. We hear about that over multiple lectures. The one thing I'm always saying is that, a result that's a little bit underwhelming is okay, but a result that's overwhelming is not. And there's a lady that I would say, what if I had put in something to make her take better? I think she would be way too full. And so this is one of those things that in the majority of my cases, I'm pretty close to being on target of where I want to be, and sometimes I'm mildly disappointed. So I always tell my patients that you're shooting for an 80–85% result, and I'm going to probably need some fillers to micro touch up little areas, and that communication on the front end is so critical. Strategy. So let's break it down. Now we're going to talk more about execution. So cheek. The cheek I divide into the anterior cheek, which is the area where you see the malar depression, anterior to the malar eminence, and then the area that resides over the malar eminence. And then the buccal area, which we'll further subdivide in a moment. And then the area I call the upside down U, which is not so much the mental sulcus, but just sort of the depression, the appearance of depression across this area. So we have to stop looking at folds and other landmarks, but just sort of bony depressions, things that you can see less soft tissue. The more soft tissue coverage you see, the better, and the more bone exposure you see, the worse. So this is more just sort of understanding it from that perspective, and the goal is to ovalize the face. And so this is just an example to show you. So let's break down the buccal further. So this is something I think I've contributed to the literature, is understanding the buccal in a more nuanced approach. So I divide into the central buccal, the backfill zone where you're seeing that zygomatic scalloping, and then the medial buccal hollow, which I think today is not so critical with proper dentition. There are not a lot of people that have significant loss in the front. When you put fat in here, you got to be careful, because sometimes it does exacerbate some of the lines and folds here when the weight is there. So I think some things you hear on the media about filling to lift up areas, that's my pet peeve, because I truly think by filling something, you can actually exacerbate areas rather than improve them. You can't fill a cheek and all of a sudden you've got a facelift result. I think this is absolutely absurd. So that's something that I try to dissuade my patients whenever I hear them saying, well, if you fill this, won't this whole thing go up? Not necessarily. So be careful in the medial expanse of the buccal zone. So this is just an example, again, just understanding the fill of the buccal area, and this one being very careful not to do that so that you don't get a wider face. And this is, again, no buccal filling so that you don't get a widening, you can get an illusion of actually narrowing. Let's talk about the eye. I think the eye is the most important area to frame and understand that, because this is the opposite of a blepharectomy or removal. It's actually adding back. Do I do blepharoplasty? Yeah, I'll show you some ideas where I do and don't. So here's a lady that I did a very conservative upper blepharoplasty. How do I decide to do that? When I see that the edge of skin is at the ciliary margin, or it looks crepey, I'll take a little bit of skin away, only a few millimeters. The rest is done with inflation. So this is when I decided. This is just done with resurfacing and fat, and obviously neurotoxins, but nothing in terms of skin removal or fat removal. Here's a lady that if you look at her, she has maybe what we call negative vector, which I call in a very formal way a bug eye. And this is something that you can imagine if I took more tissues away from her, she's going to be way overexposed. The eye is going to be over exaggerated. So this is nothing removed, but just adding it back in. This one is a combination of a transconj blepharoplasty, conservative upper blepharoplasty, resurfacing, neurotoxin, and fat. And I think when you do all those little things, so you know, I don't always just put fat in, but I almost always do start with fat, because I think almost everyone needs it, even when you have some exuberance in the lower eyelid of steatoblepharon. Oh, sorry, went too fast. This lady here has had previous work done. You can see that a lot of removal of tissues, and so all I've done is I've just lowered this soft tissue complex back down. So conservative change, but I think that's all she really needed. So the eye frame, let's break it down. Let's be really strategic about this, and if you look at this, we're going to first talk about the medial aspect. Why do I divide it? It's just easier for me to fill it. It's the same as the lateral aspect. I usually put about 1.5 cc's into each, and then the nasojugal groove, about ½ cc or so. And then you want to be careful with these numbers. I don't really vary too much. I don't go up really high numbers with this at all. Over here is just that little lateral canthal area. It's really important to come in from the separate entry and to fill the canthus, because if you don't, you're going to have a dip out here. I usually just put about ½ cc or so. Then the lateral brow, which is very important, and this area here, which is that A-frame loss, sometimes through blepharoplasty, sometimes through advanced aging, and then just sort of unifying the whole brow itself. And then I've done, not all the time, is a little bit of transition. So remember, you want as few transitions as possible. So sometimes I see even lateral to lateral canthus a little bit of a dip that I've got to do. So how do I do it? Let's break it down. You may have seen my video. I'm going to actually articulate this through still images instead, so I can narrate it here. So this is a lady that you saw in the video where she's a little bit hollower on the outer aspect, and I've done some more volumization across here. So these little landmarks I've drawn here are just so that when she's lying in a supine position, I can follow this and track this. But I fill around the anterior cheek, the outer cheek, some of the buccal zones, and you can see that I've arched this out because she needs some in this zone as well. Lateral mandible as well. I do a 3-point injection going into that area. You've heard me talk about the, we're not going to go too much into harvesting, but as you know that you really have to go through a fascial plane when you're in this area to be safe, in the inner thigh, and just really following the technique is all discussed in the book, so I won't go through that. Harvesting, you've saw the video yesterday, I hope, and just understand that just requires some basic instrumentation. I think there's a lot of rain dancing and voodoo regarding processing that you don't have to worry too much about. There's so many ways to do it. I've trained with doctors, I've done it with centrifugation, others have done it through straining and showing me great 10-15-year results that are amazing. So you just place it into this 10 cc syringe after harvesting. The Johnny Lock really helps spare your forearm from exhaustion, keeps a negative pressure on it. And then you go and remove the harvesting cannula, put the cap on it, take off the back side after flipping it around, put the cap on it. You want to sterilely centrifuge it, so these are in sterile sleeves. 3,000 RPM, 3 minutes, take it out. You get the supernatant and the infranatant. First thing you want to do is pour off the supernatant. If you do the infranatant first, the fat will fly out. And then you want to drain out the infranatant. And then the wicking is not so critical. You know, I know Sid Coleman actually leaves some oil or something to help glide it in there, but I like to take some of the excess out. And the key is not to cut your gauze, because if you cut your gauze, you can have little fibers in there. You wick off any of the residual fat, and then transfer over to 25 cc. Just helps you more expeditiously transfer. Obviously, you want to disengage some of the air that's in this area so that you don't have the fat flying across the room. Transfer that up, into the hub, and then just place it over across the way with 1 cc's for injection. These are 1.2 millimeter, which is what I typically use. For the injections, I use a 0.9. I'll show a slide in a second of that. It's always important to have the photo in the room. When you have the photo in the room, because sometimes when the patient is supine, you don't know what you're doing. I gauge and plan all my numbers before I actually walk in the room, so I've sort of memorized what I need to put in. I use a little bit of feedback during the procedure. Most of it is already premeditated before I walk through the door, and this is a reminder for me, oh yeah, I need a little bit more in the buccal area. Much more informative than when they're in supine edematous state. These are the 1.2 millimeters and the 0.9. When I go through the specific parts of the face, I'll tell you when I use what, but generally speaking, I use the 1.2s for almost everything but the temple. 0.9 is what I use for the temple. I just think it just bends too much. So the best way to conceptualize fat, this is from my book, is just to mentally conceptualize it at various levels, because it's not, people always get too obsessed with what plane you're in. I think the only plane you really got to be obsessed with is the lower eyelid area, where you have to be super periosteal. In terms of recovery, what I usually, again, communication is so important. If you communicate with a patient the things that they're going to communicate with you before they communicate with you, they'll feel more comfortable. So I usually tell my patients on the night of the procedure, here are the 5 things that are going to make you feel scared. One is you may feel bumps inside your mouth because the mucosa is so thin, the fat may bulge in there, and that will settle out, okay? So just to let you know that. The other thing is sometimes you may look like Jay Leno. I say that and say they don't freak out because they can bulge in the chin area. That's normal, so not to panic with that. That will settle out. Your brows can look like Neanderthals. I use those words because that usually freaks them out, and they go, oh wow, I get it. That's going to settle out. I say your cheeks going to look like chipmunks. They will settle out. I will say that you cannot smile normally because it's so tight. You will feel tight. When you feel the fat will feel hard and firm. And those are the things that will all settle out. And so I always try to tell my patients that. And I always tell them that you may need a touch-up down the road. There's going to be some evolution and changes over a period of this year that are not consistent for every single person. And if you articulate all that to the patient beforehand, again, you know what you've heard me say is that an education is told to the patient before they have the procedure. Any excuses, but wait a second, Dr. Lamb, I didn't know that was going to happen to me. So I always encourage you, you've seen me end this with all my talks, to really be artists out there and to really understand the face from an artistic level, and rather than just being a technician. Thank you very much.